Good morning, everyone. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today covers face, brow, and compound presentations. So, what we wanted to discuss today: face presentation, including definition, epidemiology, positions, etiology, diagnosis, mechanism of labor and management, and lastly, the maternal and fetal complication. As regard the brow presentation, the definition, diagnosis, and the management, and in compound presentation also we need to know the definition and diagnosis and management. Let us start with face presentation, which is cephalic presentation in which the head is completely extended. As you see in the picture, this head completely extended. That's why the lowermost part of the fetus is the face. So we call it face presentation. The presenting portion of the fetus is the fetal face between the orbital ridges here and the chin. Okay? Face presentation account for 1 in 500 or 1 in 600 deliveries. Which is more common, mentum and posterior or mentum anterior? Mentum anterior is more common and occurring more than 60% of face presentation. That's because mentum anterior is the extended head of occipital-posterior, which is deflexed, so becomes more deflexed, becomes extended. So turn from occipital-posterior to be a face presentation, specifically mentum anterior. That's why mentum anterior is more common than mentum posterior. Also, the risk groups, black women and the multiparous women. What is the denominator in face presentation? Is the chin or mentum. That's why we call it, if the mentum is anterior, we call it left or right mentum anterior. And if it is posterior, we say left or right mentum posterior. What is the etiology? The etiology of primary face presentation, which occurred during the pregnancy, may be idiopathic or due to congenital anomaly like anencephaly, as in this picture, absence of the vault of the skull and the part of the brain, forebrain and cerebellum atrophied, or dolichocephaly. Dolichocephaly like this one, long anterior posterior diameter of the head, as in this one and this one. This is called dolichocephaly. Or due to short neck of the head or coils of the umbilical cord around the neck, causing extension of the head, or tumors in the anterior part of the neck, like thyroid tumor, like bronchial tumor, or any tumor in this region causing extension of the head of the fetus. Also may be related to functional problem in the muscles, extensor muscles of the neck, hyperextension of the neck due to spasm of the muscle of the back of the neck. But during labor may be maternal causes or fetal causes, and we call it secondary face presentation, which occur during labor. Maternal causes including contracted pelvis and abnormal shaped pelvis, platypus pelvis, preterm delivery, lateral obliquity of the uterus, pelvic tumors, polyhydramnios, placenta previa and bicarnate uterus, and multiparity with laxity of anterior abdominal wall muscles. As regards the fetal causes, as we mentioned before, anencephaly and leukoencephaly and meningeal tumor of anterior fetal neck, multiple loop of cord around the neck, intrauterine fetal death, premature baby, large fetus, or multiple pregnancies. How to diagnose? By abdominal examination. During inspection, you will find flattening of the lower abdomen in mentum anterior with apparent fetal movement because the lumps is near the midline, so you can see the fetal movement around the midline. Okay. Sometimes you may see suprapubic groove, as in minto-posterior here. Okay. You will find suprapubic groove. Why this suprapubic groove? Due to the area between the neck and the extended head, this region. So you may see suprapubic groove. What about the grapes? Fundal grape, we will feel the buttock with its characters, soft, irregular, and palatable. Umbilical grape, the fetal back is difficult to palpate actually. And it looks like S shape, as you see in this picture, S shaped back. And lost the convexity of C shape, as in occipital anterior. So in sacro-posterior here, the back looks like letter S, and difficult to palpate it. First pelvic grip, the head is felt larger, and the head prominence is felt in the same side of the back. This head prominence is felt at the same side of the back. What about the second pelvic grip? Of course, the head is extended, so we expect the occiput to be higher than the sinciput. Okay? So we can diagnose that this head is extended during second pelvic grip, which detect the fetal head attitude, because here the occiput is higher than the sinciput, so the head is extended. What about auscultation of the fetal heart sound? Which is the side to hear the fetal heart sound? The best side is below the umbilicus, near the midline, on both sides of the midline. Okay? In this area. Look to the red arrow, this area, and this is for left minto anterior, and this is for right minto anterior. Ultrasonography can confirm diagnosis after we finish the clinical examination. We can confirm face presentation by ultrasonography. Like this picture, you can see the head is extended. This is the fetal spine, and this is the head, and you can see the head turned to the back, so it is extended head. Okay? Also, ultrasound is important to detect the fetal size, the presence of any anomaly like anencephaly or leukocephaly or meningocele or multiple pregnancy. So ultrasound can detect many important items in this malpresentation. What about the vaginal examination? Of course, take care while doing BV if you are expecting face, because you may feel the eyes. So try not to use something irritant to the eyes or to the skin of the face. Okay? Early in labor, the presenting part is expected to be high. The cervix is not fully dilated. There is softer and irregular presenting part because it is not vertex, it is face. So it is different than the vertex, which is hard, smooth, palatable. Here, I feel the face with its characteristics. What is the characteristics? The supraorbital margin, the nose, the mouth, the malar area, the chin or mentum. What about during labor? The landmark of the face may be obscured by edema and may lead to difficulty in differentiating face from frank breech. So, face is a differential diagnosis for frank breech. Both of them has 3 bony prominence and 1 opening. In breech, there is 2 ischial tuberosity and the anus in between, and all of them at straight line. While in face presentation, I have also uh, 3 bones, the maxillary bone, two maxillary bone, and the chin, okay? And the opening the mouth, and if the finger introduced inside the mouth, there may be suckling, okay? So these spoons forming corner of a triangle, while in frank breech, the two ischial tuberosity and the sacrum at the same straight line with the anus, okay? Okay. What about the mechanism of labor? Take it as the rules. Men to anterior can have a chance for delivery, persistent men to posterior, no chance for delivery, and the patient in need for cesarean section. So, persistent men to posterior should be cesarean section, while men to anterior, there may be vaginal delivery. But the descent, the steps of labor, as you know from previous occipital anterior delivery, before descent, engagement, increase flexion, internal rotation, delivery of the head in extension, then restitution and external rotation. This is for occipital anterior, which is normal presentation. What about face presentation? As regards the descent is slower. The descent of this head in the pelvis, which is presented by face, is slower. Engagement occurs late. The engaging diameter is the submentopragmatic, which is 9.5 centimeter, and engagement occurs in oblique diameter of the pelvis. Okay? Contrary to the vertex presentation, which both suboccipitopragmatic diameter and the biparietal diameter lying in the same plane, in face, both diameters lie in different planes. So engagement occurs first with the submentopragmatic diameter and the bitemporal diameter in case of face presentation. Then followed by parietal diameter. That's why the head is deflexed, because the bitemporal diameter enters the pelvis first. And this is the cause of being extended head. Extended head. Then there is more extension, and the face meets the pelvic floor and becomes fully extended. When reach the pelvic floor, internal rotation 8 circle anterior will occur toward the symphysis pubis. Then delivery of the head, when the chin hangs behind the symphysis pubis, delivery of the head will occur in flexion. If you remember occipital anterior, which is the normal presentation and the commonest, delivery of the head in extension, while delivery of the face in mento anterior in flexion. Any other malpresentation, the head is delivered in flexion? Yes. After coming head in breech, also delivered in flexion. Also malposition like occipital-posterior, direct occipital-posterior face to pubis, the head is delivered in flexion. Okay? But occipital-anterior is in vertex presentation is delivered in extension. So face mento anterior will be delivered in flexion, as in this picture like that. Then lastly, the restitution and the external rotation. Restitution, the neck untwist and turn 8 circle back toward the original side in the opposite direction of internal rotation. And then external rotation, the chin rotates another 8 circle in the same direction of restitution, okay, due to rotation of the anterior shoulder. What about mento posterior? We can divide them into two groups. 2/3 of the cases long anterior rotation of 3/8 circle will occur for the chin, and the baby will be delivered as minto-anterior. While 1/3 of cases will be persistent minto-posterior, and this is undeliverable and indicated for cesarean section. So let us start with the 2/3 of the cases with long anterior rotation. Descent is slow, of course. Engagement is delayed. There is increased extension. Then when reach the pelvic floor, the chin will rotate 3/8 circle anterior. Need uterine, good strong uterine contraction. Head delivered in flexion, as we mentioned before, because it becomes minto-anterior. This minto-posterior rotates 3/8 circle, so like this one, rotates 3/8 circle, become like this one, minto-anterior. So 3/8 circle rotation anterior to be delivered as minto-anterior, and the head will be delivered in flexion, then restitution and external rotation as usual. What about the remaining third of the cases which will be persistent minto-posterior? Either internal rotation 8 circle anterior leading to transverse arrest, as is undeliverable, also needs cesarean section, or persistent oblique minto-posterior, also needs cesarean section, or posterior rotation of the chin 8 circle resulting in direct minto-posterior, as in this picture, direct minto-posterior, and this is undeliverable. Why? Because the head and face is delivered in flexion, because the head is already hyperextended. But in direct minto-posterior, the head cannot be delivered in extension, in flexion, sorry. The head in this position, direct minto-posterior, cannot be delivered in flexion, as you see. So this persistent minto-posterior will be delivered by cesarean section. In case of direct minto-posterior, there is arrest due to delivery must occur in extension, as we mentioned, and the head already maximally extended. This is as regards the occipito-anterior. I mean that the chin is carried into the hollow of the sacrum, and because of the fact that the sacrum is 10 centimeter, which is longer than the neck, which is 5 centimeter, the head prominence will enter the pelvis with the shoulder leading to impaction. Okay, the head and the shoulder will be impacted in the pelvis. In this case, the diameter which is impacted will be large, and sometimes we call it thoracopragmatic diameter. This shoulder with the head. What about the course of labor? We expect the presence of uterine inertia. The uterus exhausts from the strong uterine contraction, then abnormal uterine action and inertia, early rupture of membrane, prolongation of second stage, descent is delayed, and the wind face is distending the vulva. The biparietal diameter has only just entered the pelvis. Repeated vaginal examination to assess the presenting part and the progress of labor may be injurious to the baby, leading to bruises, ecchymotic patches in the face, as well as damage to the eyes. So be gentle and be careful while you are doing BV in a case with face presentation. Perineal laceration at the head is borne by flexion. So there is distension in the perineum and may cause perineal laceration. In face minto-anterior, spontaneous delivery occur with slight delay, but face minto-posterior, 2/3 of case rotate to be minto-anterior and may undergo spontaneous delivery as regards the course of labor. The third, or the remaining third, will be persistent minto-posterior and is indicated for cesarean section. What is the management of phase presentation? During antenatal evaluation, when we diagnose anencephaly by ultrasound, induction we never diagnose to avoid dystocia, which is common also, another problem common with shoulder dystocia, which may cause obstructed labor. Also, malpresentation like face presentation is common with anencephaly. So when we diagnose anencephaly, it's better to do termination of the pregnancy, but according to the patient opinion. So you should take a consent from the patient. She should accept the termination, and you should counsel her about the problem. The final decision is the decision of the pregnant woman. What about the normal fetus? Can be managed by elective cesarean section if there is contracted pelvis or fetal-pelvic disproportion or macroscopic baby or any other complication with pregnancy or previous cesarean section, and in mento-posterior cases. Trial labor can be given to the young patient with average size fetus and capacious pelvis, and if she has a history of previous normal delivery and normal shaped pelvis and the mento-anterior position. Labor management in mento-anterior involve careful monitoring of the fetal heart rate and the labor progress. Of course, you should use partogram to detect any protraction in cervical dilatation or descent of the head, or even the arrest of any of them. Normal pelvis and the progress of labor leads to spontaneous delivery. Presence of disproportion or arrest or protracted cervical dilatation or arrest of the descent or dilatation will be shifted towards cesarean section. Mento-posterior, if there is disproportion, cesarean section from the start. If there is normal pelvis, watchful expectancy. Why? You are waiting or hoping for the 3/8 circle anterior rotation of the chin. If this happens with good uterine contraction and the adequate pelvis and the small sized baby, yes, you can continue with vaginal delivery. But if persistent mento-posterior, either oblique posterior or direct mento-posterior or transverse or mento-transverse, all of them will be delivered by cesarean section. Actually, more than half of cases of phase presentation in general are delivered by cesarean section because it is more safe than vaginal delivery. Attempts to manually convert phase presentation to vertex or forceps rotation of persistent posterior are contraindicated as they can be dangerous. So don't do manual rotation or forceps rotation in case of phase presentation because it is dangerous and it is of no use in modern obstetrics. What is the complication expected in phase presentation? Maternal and fetal complication. Maternal including obstructed labor, exposure from prolonged labor, laceration of the genital tract, the perineal area, and the vagina, and cervix, postpartum hemorrhage or intrapartum hemorrhage, infection and purpurar sepsis, and complication of operative delivery. Fetal complication include fetal edema, fetal tissue trauma, bruising, cord prolapse and fetal distress, and fetal asphyxia, complication of operative interference, perinatal mortality due to congenital anomalies or cord prolapse. Let us go to the brow presentation, which is also cephalic presentation when the head is midway between extension and flexion. As we know, well flexed head will give me, in cephalic presentation, will give me vertex. Completely extended head will give me, in cephalic presentation, face presentation. Okay? But what about midway between flexion and extension? This is the brow presentation. It is the most unfavorable of all cranial presentation because the engaging diameter, which is the mean to vertical diameter, is 13.5. This longitudinal diameter, the mean to vertical diameter, is larger than any diameter of the female pelvis. So how this head can descend through the pelvic brim or the pelvic inlet to the cavity? So this is a big problem for brow presentation. Brow presentation is considered the rarest of all malpresentation, approximately 1 in 1,500 deliveries are brow presentation. We have two types, primary and secondary. We call it primary. This is for persistent brow due to persistent cause. So, and diagnosed during pregnancy. Secondary brow presentation occur after the onset of labor. The secondary brow is often transitory and the head either flex to be vertex, so the head may change from brow to vertex. By what? By flexion. If this head is flexed, it will be vertex. If it is extended, it will be face presentation. Okay? But persistent brow is undeliverable, as we mentioned before, because of mean to vertical diameter, which is 13.5 and larger than any female pelvic diameter. Okay? So, what is the etiology as regard brow? Simulating face, the same causes, maternal and fetal, contracted pelvis, preterm delivery, lateral oblique uterus, pelvic tumor, placenta previa, bicarnate uterus, polyhydramnios, and the multiparity. For fetal causes, the malformation like anencephaly or tumor of the anterior fetal neck or multiple cord around the neck or prematurity, intrauterine fetal death, large fetus, or multiple pregnancies. So the etiology is similar to that of the face. Any cause can lead to deflexed head or extended head will give me either brow or face presentation. This is the idea. How to diagnose? Abdominal examination resembles those with face, but here the sensible during second pelvic grip will feel that the sensible and the occiput at the same level because it is midway between flexion and extension. This is brow. So they will be at the same level. What about vaginal examination? Expected to see or to feel slow dilated cervix, protruding membrane, maybe premature rupture or preterm rupture of membrane. The presenting part is high and there may be cord prolapse. Palpate the presenting part, you will find the brow. This area is called the brow. This is the frontal bone. And the denominator here is the frontum. Okay? The area between supraorbital ridge and bregma or anterior fontanelle. This area between supraorbital ridge and bregma is called brow. This is the presenting part. And as we mentioned before, it is undeliverable vaginally. Should be cesarean section if persistent brow. It is not, in case of brow presentation, it is not possible, as you see in this picture, either to feel the chin, you can see it's away from you, you cannot feel the chin, okay? And if you feel the chin, So this case is face presentation, not brow presentation. Be careful about this point. In brow presentation, you cannot reach the chin. You cannot feel the chin. And if you feel the chin, this case is a face presentation. Also, you cannot feel the occiput. So it is not vertex presentation. Okay? But this brow, if it is transient and the head becomes flexed, it will be shifted to vertex. If becomes extended, it will be shifted to be face. If persists as brow, you will feel the frontal bone and supraorbital ridges, and the other boundary is the bregma here. We mentioned before that the mento-vertical diameter is larger than the any pelvic diameter, so engagement cannot happen except if the brow was transient and converted to be face or vertex, so the diameter will change. The engaged diameter will be changing. So spontaneous labor can take place in very rare situation when there is a large roomy pelvis, very small baby return or low birth weight baby with a strong uterine contraction. And this is a very rare situation. Early in the first stage, the management, if there is disproportion, fetal pelvic disproportion, we will do cesarean section. If the pelvis is adequate and normal, and we can suspect that this may be transitory brow, we can give a chance for trial of labor because this brow may be changed to be face or vertex as we mentioned before. If not, and the persistent brow, still cesarean section is the only line of treatment. In second stage, already there is persistent brow, so you should do cesarean section because it is the best and the safest method for the fetus and the mother. What is the complications of brow presentation? Maybe obstructed labor, uterine rupture, or prolonged labor, risk of operative interference, perineal laceration, berberal sepsis, and the fetal complication include prolapse of the cord, perinatal mortality, soft tissue trauma, and prolonged head compression may lead to brain damage and also asphyxia and cerebral palsy. Let us go to the compound presentation. As you see in this picture, compound presentation can be defined as presentation of fetal extremity alongside the presenting part. In this picture, the presenting part is vertex and the arm alongside the head, alongside the vertex. So, compound presentation is defined as presentation of fetal extremity as arm or foot alongside the presenting part. Most compound presentation are either hand or arm, as in this picture, with fetal head. Okay? Compound presentation, is it common? No, it is not common. Complicate from 1 in 700 to 1 in 1,000 deliveries. Risk factors include prematurity polyhydramnios, rupture of membrane early at higher station, and multiple gestation and external cephalic version. Cephalic presentation with prolapse and the breech presentation with prolapse of hand or arm. So I can see either arm beside the presenting part or leg. Okay? So we can divide compound presentation into two main groups. Cephalic presentation with prolapse of upper limb, lower limb, or arm and the leg together. or the other group breech presentation with prolapse of hand or arm, as this picture vertex with arm, this picture vertex with leg and foot. Okay, so any extremities, upper limb or lower limb, alongside the presenting part is called compound presentation. What is the etiology? All conditions that prevent complete fitting and occlusion of the pelvic inlet by the presenting part will cause compound presentation. The most common is prematurity. Other causes include high presenting part with ruptured membrane, twin pregnancy, contracted pelvis, and the multiparity with laxity of anterior abdominal wall. As you see here, this is vertex and this is arm beside the head. How to diagnose compound presentation? During antepartum obstetric ultrasound, you can discover it accidentally, okay? Or palpated during cervical examination, typically during early labor. The examiner will feel irregular shape beside or in advance of the vertex or breech. So this limb will feel something irregular beside or in advance to the presenting part, which is vertex or breech. In this picture, it is vertex. Compound presentation may not be diagnosed on admission to labor unit if the cervix is long and closed, but will be discovered as labor progresses, because you will feel it through the cervix when it is open. The condition is suspected when the head remains high or unengaged after rupture of membrane, or when there is delay in the active phase. What is the mechanism of labor? The mechanism is that of the presenting part. According to the presenting part, is the presenting part vertex or breech, and accordingly. However, because the diameter is increased, the chance of arrested progress is greater as regards progress of descent and the progress of cervical dilatation. In many cases, labor is not obstructed and the presenting part is brought to the outlet. Or maybe this limb may recede up and the problem is solved spontaneously. What about the management of compound presentation? There is debate about the management because some experts recommend attempting to reposit the fetal extremity while others discourage this practice. Some believe that we can do repositioning of this arm away from the vertex up while the uterus is relaxed, not contracted, okay? Then assistant will help with fundal pressure so the head will descend or the vertex will descend down, occupying the inlet of the pelvis, and the arm becomes up, so the problem is solved. This is, some believe in this, but they advise to do it gently, very gently, so not to cause any trauma. Others resist to do this manipulation and say either this limb recedes spontaneously, or if there is arrest of descent or dilatation, you should do cesarean section because it is more safe to the mother and the fetus. So this is a matter of controversy. So for women with normal progressing labor, we favor observation alone. Also using partogram is very important. Occasionally, the presenting part will simply push the extremity aside, or the fetus will retract the extremity as labor progresses. If descent of the presenting part appears to be slowed, or obstructed by the extremity, then gently pushing the small part upward into the trunk cavity as I mentioned before, while simultaneously the fundal pressure by the assistant. What about if there is failure of the compound presentation to resolve spontaneously, or after this gentle maneuver there is failure? The best treatment will be cesarean delivery, especially or specifically if there is protracted or arrested cervical dilatation and descent, or another emergency situation which is umbilical cord prolapse while the cervix is not fully dilated. So you should do cesarean section as an emergency case. What is the prognosis? In most cases, labor results in an uncomplicated vaginal delivery. Sometimes there is prolonged labor and maternal and fetal distress. As regard compound presentation may be associated with injury to the fetal limb, because this fetal limb, imagine, trapped between the head and the pelvic pool, so liable for ischemia for long time. So ischemic necrosis may happen in the arm, and there is reported cases published about ischemic necrosis of arm and even amputation, reaching up to amputation. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.